All right, here we go. Chapter 18, Part 4, Cardiovascular Emergencies. So if all of you guys thought, man, I'm glad we stopped talking about heart failure, well, we're not completely done, so hang on. So let's talk about assessment. So some patient-reported symptoms. When we talk about that, we're talking about like sudden onset of shortness of breath, so may experience, some acute dyspnea, worsening shortness of breath, so that there's a gradual increase in breathlessness over hours or even days, which may persist even at rest. Now, the risk factors, we see a likelihood of a cardiac origin is higher if the patient has a history of a previous heart attack, some hypertension, valvular disease, and then even some other cardiovascular conditions as well. Now, they're going to have a lot of sleep related issues. So trouble sleeping, with people that are in heart failure, they can report difficulty sleeping, potentially due to orthopnea or even paroxysmal nocturnal dyspnea. Remember, they've got to change their positioning around. So some of the general symptoms we see is fatigue or weakness, and those are, just common complaints among heart failure patients. And then some cognitive difficulties might be something that's going on as well, and that's just trouble concentrating. That's possibly due to the hypoxia. Might see some other symptoms, so some GI symptoms, some nausea and loss of appetite, as well as you can imagine, cardiovascular symptoms. So just those feelings of faintness. We've talked about palpitations, maybe an irregular or rapid pulse. Well, so we want to talk about here, about inquiring about some medications. So we want to think about specifically beta blockers or even calcium channel blockers when we're looking at cardiovascular symptoms. Now, psychological symptoms, some restlessness and anxiety and confusion can arise, once again, probably from hypoxia. Now, we see a physiological response. We were talking about it just at the end of the last one, and we get that sympathetic nervous system activation. So we see a rapid heart rate, rapid respiratory rate, pale, cool skin, diminished peripheral pulses, increased work of breathing. Now, all of that, when we start talking about increased work of breathing, we probably are expecting that hypoxia is worsening. So that could lead to some cyanosis and frequent coughing. And that coughing that we're talking about, it can produce pink and frothy sputum. Because what happens is you get this buildup of that fluid, it causes those rales or crackles and some wheezing as well. And then the pink frothy stuff typically is from those little capillaries bursting, and some blood is mixing in with that as well. Now, some signs of right ventricular failure, JVD we mentioned, it's visible if the right ventricular failure accompanies left ventricular failure. And then as heart function declines, the heart rate may slow, blood pressure can fall, cardiac output decreases significantly, and then we start thinking about maybe cardiogenic shock, and that occurs when that heart failure is associated with hypotension. So some overlapping signs and symptoms that we might see, many symptoms of heart failure, such as shortness of breath, fatigue, edema, they can also occur in a lot of other medical conditions. So a few of those could be COPD. They can present with dyspnea and cough and fatigue, as well as pneumonia and anemia, which can lead to fatigue and weakness. And also that mimics heart failure symptoms. So kidney disease, so they have some fluid retention, and edema may confuse the diagnosis, as well as liver disease. So that can present with abdominal swelling or ascites and peripheral edema, and then even up to a PE. So that can just may cause that sudden shortness of breath and chest pain. So management, obviously one of the first things you see on there is to offer reassurance. So, when we can, we need to provide some emotional support to help alleviate some anxiety and stress. And then positioning is going to be a really big thing. So place the patient in a sitting position with their feet dangling. What that does is that encourages some venous pooling in the legs and reduces venous return to the heart. Also decreases the work of breathing, making it easier for the patients to breathe. And then, of course, with some monitoring that you see listed, obviously a pulse ox, we need to get some O2 on them, keep everything between 95 and 99. Now, of course, depending upon your protocols, you probably want to consider some non-invasive positive pressure ventilation. So consider that to manage that pulmonary edema that's associated with heart failure. Don't forget about those contraindications. So if they have a compromised airway or altered mental status, maybe if they have a risk of aspiration or a pneumo, or then obviously if their systolic is less than 90, that's not going to be a very good candidate for that as well. Now, in certain cases, it may be necessary to use an advanced airway and move on up the ladder of our airway. So, talking about respiratory monitoring, obviously waveform capnography is going to be a good thing. So we want to continuously monitor the patient's respiratory status to assess ventilation and detect any deterioration as well. So as we're with these patients, we want to make sure that we're limiting their physical activity. So we're advising a patient to, limit the activity, reduce strain on the heart. Cardiac monitoring is going to be a big thing. We want to make sure that we get them on a monitor, get a 12 lead, look for arrhythmias, maybe ischemic changes, IV access. Most of this kind of stuff shouldn't be hard to figure out. We want to make sure that we get an IV. Now, one thing with these patients is you want to make sure that you don't fluid overload them, because fluid can certainly get into the lungs. So, if you're using an IV bag and tubing, then infuse fluids at just that keep vein open rate, that KVO rate, approximately about 30 mils an hour. So also what's important with that is you want to document the amount of fluid remaining in the bag as you deliver them to the ER. And then pharmacological therapy. So obvious, all of this depends upon your protocols, but you want to follow, some heart failure, pulmonary edema type protocols. You might consider administering some sublingual nitro to reduce both the preload and the afterload. That helps to support cardiac output. And then furosemide or Lasix, it's not currently recommended for treating heart failure and acute pulmonary edema in this context. And then one thing that you see here is to transport the patient to avoid lights and sirens. That's obviously a protocol thing. However, the thought process behind that, and it makes sense, is we want to avoid using those lights and sirens for these patients to prevent increased anxiety and heart rate, as well as blood pressure. Now, ventricular assistance devices, they serve as a surgically implanted device that assists patients with severe heart failure, and it just acts as an artificial ventricle. So these VADs, they do not rely on the heart's contractility or electrical conduction, allowing them to effectively support circulation even when the heart is severely compromised. And there's several different types of these. We have the LVAD, which is the left ventricular assistance device. That's most commonly used as left ventricular failure is more prevalent. And then we have the right ventricular assistance device. So that's used when the right ventricle requires support. And then we also notice that we have biventricular assistance device. And that supports to both the left and the right ventricles whenever it's needed. So what are these? What are these VADs, these ventricular assistance device? Well, it's a mechanical helper for people with severe heart failure, and they kind of just act like an artificial ventricle, helping the heart pump blood. So there's several different parts of it. We have the blood pump. That's the heart of the device, and it moves the blood. And then, of course, there's going to be some tubing, and there's an inflow cannula, and it brings blood into the pump, and an outflow cannula. It sends it back into the body. Of course, you need a power source, and then there needs to be some alarms that say, hey, something's not quite right, something's going wrong here. Now, there's different classifications here. So we have a type of blood flow device. So a type of blood flow. So some VADs, they provide a continuous flow, while others mimic the heart's natural pulse. And they can be short-term for emergencies, intermediate for waiting on a transplant, or long-term for ongoing support. Now, these VADs can be pneumatic, so they're using air pressure, or they can be electric, and they can be internal, so they're implanted in the body, or even external, which obviously is outside the body. So one thing to keep in mind is that the patients with these ventricular assistance devices might have weak or absent pulses, so it can make it a little tricky to get blood pressure readings with a manual cuff or to check pulse ox as well. So let's talk about a couple of different types of these and some potential complications that we might see. Now we got transcutaneous ventricular assistance devices, And these are entirely external devices, meaning both the pump and the power source are outside the body. They're often used for just some temporary support. And then there's implantable ones, so that the pump is implanted inside the body while the power source remains external. And that setup allows for longer term support. Now, the LVADs, they take blood from the left atrium or the apex of the left ventricle, and that blood is pumped into the ascending aorta, and that helps to improve blood flow to the body. And then with the RVADs, or the right ventricular assistance device, they draw blood from the right atrium and pump it into the pulmonary artery, and that assists the right side of the heart. Now, as you can imagine, there can be some complications. So some to watch out for is obviously device malfunction or failure. Sometimes the device may not work as intended, which can be obviously pretty serious. And then thromboembolism, and that refers to blood clots that can form and potentially travel to other parts of the body, and that in turn causes blockages. Now, bleeding as well, since these devices often require anticoagulation, there's an increased risk of bleeding. And then heart failure. So despite having a ventricular assistance device, the underlying heart condition can still lead to heart failure. And then infection. So any surgery or device can introduce a risk of infection, especially at the insertion sites. And then dysrhythmias as well. Cardiac tamponade, so when that fluid builds up around the heart, as well as aortic insufficiency. And that can happen if the aortic valve doesn't close properly, and that leads to the backflow of the blood. And then, of course, we mentioned before infection, but we can take it a little step further. So sepsis, so that severe infection and it spreads throughout the body, obviously that's going to need some immediate attention. So let's talk about how to assess for potential ventricular assistance device pump malfunctions, and then what to do if these issues arise. So some things to check when you think you might have, when you're assessing for a pump malfunction. You always want to check for any alarms on the device. That can indicate issues that need immediate attention. And then auscultation. So listen for kind of just that hum sound from the pump. A consistent hum is a good sign that the pump is functioning. And then some signs of hypoperfusion. So you want to look for signs that the patient isn't getting enough blood. So thinking about pale skin, confusion, low blood pressure. Now, if you do suspect a malfunction and you're needing to kind of troubleshoot, here's kind of a couple of ideas, but one is to contact someone that's trained in this. So, if the patient has someone who is trained in this care, reach out to them for guidance. Maybe they're already on scene or whatever. Make sure you check all your connections to the system, the controller, make sure they're all secure. And then if needed, change the batteries or replace the system controller. And then have the patient stop all activity and monitor how they tolerate the situation. This can help assess whether the pump is functioning properly or not. Now, also, you can contact the VAD coordinator. They can usually provide some critical support and guidance, during an emergency. Now, however, in case of cardiac arrest, so if a person with one of these experiences cardiac arrest, it's be a good thing, if possible, to contact their coordinator. And then if the patient needs some procedures like defibrillation or cardioversion, be cautious not to place the pads directly over the pump, and that's important to avoid damaging the device. And then make sure to bring all the device-related equipment when you're transporting a patient to a facility that may not have capabilities for these devices. All right, let's shift gears. So let's talk about cardiac tamponade. We'll focus on kind of some pathophysiology and just how it develops. So what happens is that a cardiac tamponade occurs when fluid accumulates in the pericardial sac. So remember, that's just that area around the heart. And this buildup puts pressure on the heart, which can hinder its ability to contract effectively and restrict how much blood can fill the ventricles. So as a result, the heart struggles to pump blood efficiently, and that leads to reduced cardiac output. Now, there's a couple of different ways that this can develop. So one of them is a gradual development, and then we can see a rapid development. So with the gradual development, it can happen slowly, often due to conditions like infections, so pericarditis or tumors even. Over time, the body can adapt to the increasing pressure, but eventually it overwhelms the heart's ability to function properly. Now, in other cases, such as after heart surgery or following the insertion of pacemakers or central venous catheters. Tamponade can occur suddenly, so we'll talk about rapid development. So traumatic injuries like stab or gunshot wounds, they can also cause rapid accumulation of blood in the pericardial space, and that leads to acute tamponade. So patients with cardiac tamponade are often too ill to provide a detailed medical history. So some of the symptoms we might look for is like some anxiety and restlessness, so shortness of breath, because that pressure on the heart can make breathing pretty difficult, and then chest tightness, feel a sensation of pressure as well as dizziness. Now, always suspect a tamponade in patients with penetrating chest or upper abdominal wounds. If it's not trauma related, consider a history of conditions like pericarditis or end-stage renal disease. Now, sometimes people get these a little mixed up, so there is some differentiation between a tension pneumo and a tamponade. In tamponade, the lungs aren't affected, so we'll get equal breath sounds on both sides, as well as the trachea will be midline. Now, however, with this, we do have some classic signs of cardiac tamponade, and that's usually termed like Beck's triad. And what we see is a JVD, so some swelling of those neck veins, and then we see hypotension, and then we'll see muffled heart sounds as well. And that's due to the fluid around the heart. So, one thing to think about though is all of these signs are only present in about half or even less of our patients. So that's not necessarily a great thing to just rule someone in or out based on that. It's just something to keep in mind. And then some other signs: cold, mottled, or cyanotic skin, tachycardia, weaker absent peripheral pulses. That just indicates that reduced blood flow, narrowing pulse pressures, and then pulsus paradoxus. So that's a late sign where blood pressure drops during inhalation, and it may be absent if the patient is severely hypotensive. And then these symptoms with this a lot of times can mimic those of heart failure as well. Now, when on the ECG is, obviously of limited value, but it may show electrical alternons, and that's a variation in the amplitude of heartbeats. And I've put that little picture down there for you. So that occurs because fluid builds up around the heart in the pericardial sac, creating pressure and restricting the heart's movement. But then as a result, the heart moves slightly with each beat, and that causes the electrical signals to change in strength or shape from one beat to the next. And this creates that alternating pattern seen on the ECG. So when we move on to talk about management, obviously we want to address life-threatening hemorrhage in the event it's a traumatic issue. So we want to control any bleeding as priority. Oxygenation and ventilation are going to be really important. So we want to also monitor their oxygen levels. We want to keep them between 95, 98, get a monitor on, and then transport. And obviously we want to get an IV as well, because the ultimate treatment for this is there's nothing we can do in the field other than quick and prompt recognition. What needs to happen is a pericardial centesis. So, that procedure involves inserting a needle into the pericardial sac and withdraw that excessive fluid. So even withdrawing as little as 50 mils can lead to significant improvement. And so we want to make sure that we take them to a facility that's capable of performing this procedure. All right, cardiac shock. So cardiogenic shock. Pretty serious condition. It's characterized by a severe impairment of the heart muscle function, and this results in the heart's ability or inability to pump enough blood effectively. Now, the primary consequence of cardiogenic shock is that decrease in cardiac output, which leads to inadequate tissue perfusion. So essentially, the organs and tissues, they don't receive enough blood flow, which can cause them to become starved for oxygen and nutrients. Now, the most frequent cause of cardiogenic shock, left ventricular failure. So it's often secondary, though, to an acute MI, commonly known as a heart attack, obviously. And when the left ventricle is damaged, it can't pump blood efficiently, and then that leads to this critical condition. So cardiogenic shock, it can arise as a complication of various types of shock, and that's regardless of the underlying cause. In these cases, the heart is unable to maintain adequate blood flow due to the compromised state of the body. So this condition can also occur when myocardial contractility So, the heart's ability to contract is reduced, which may happen due to a couple things. So, prolonged cardiac surgery, so maybe they have an extended surgical procedure that can stress the heart muscle. Ventricular aneurysm. An aneurysm is in the ventricular wall that can weaken the heart's ability to pump effectively. Cardiac arrest, so following a cardiac arrest, and even a ventricular wall rupture. So this severe condition can lead to significant loss of pumping ability and rapid deterioration. So after resuscitation from cardiac arrest, patients may experience transient cardiogenic shock. And this temporary state can occur as the heart struggles to resume normal function and then restore adequate blood flow. So some risk factors. We see older age is one. We see older age is one, so that risk of cardiogenic shock, it increases with age as the heart's function may naturally decline over time. Of course, in MI, they're particularly concerning because they can significantly affect the heart's pumping ability, and that leads to shock. Diabetes, many diabetics often have some underlying cardiovascular issues that can increase the risk of both heart attacks and cardiogenic shock. And then hypertension, so some chronic high blood pressure. Multivessel CAD, or coronary artery disease, so those blockages in multiple coronary arteries, it can severely compromise blood flow to the heart muscle, and that heightens the risk of shock. And then previous MI, or a peripheral vascular or cerebral vascular disease. So conditions affecting, the blood flow in the peripheral or cerebral circulation can indicate broader cardiovascular issues, and then that raises the risk of cardiogenic shock. So let's talk about an assessment here. You see we've got 4 points. We've got warm and dry, warm and wet, cool and dry, and cool and wet. Let's talk about what these kind of assessments, what we're talking about. So some characteristics that we're talking about, we're in this clinical presentation for cardiogenic shock. So warm and dry, these patients may exhibit symptoms that's consistent with heart failure, such as fatigue or reduced exercise tolerance. However, there's an absence of fluid buildup in the lungs, and that means no signs of pulmonary edema. And then you'd see an increased heart rate often present as the body's attempt to compensate for that reduced cardiac output. And then we see warm and wet. So vasodilation is one thing that, this state's often associated with peripheral vasodilation, which can lead to a feeling of warmth. And then pulmonary congestion, so evidence of fluid accumulation in the lungs, and that leads to symptoms such as shortness of breath, cough, bad lung sounds, and then tachycardia and fever. So that heart rate remains elevated, and the patient may also present with fever, indicating a potential inflammatory or infectious process. So hopefully you're starting to see, as we talk about warm and dry, we see no pulmonary congestion, they're warm. Then we see warm and wet, vasodilation, as well as they do have pulmonary congestion. So kind of hopefully those two pieces are kind of making some sense. Now, cool and dry presentation, when we're talking about cardiogenic shock, we see some peripheral vasoconstriction, so that body responds to low cardiac output by constricting those blood vessels. That leads to cool extremities, but we don't see any pulmonary congestion. We're talking about dry. Tachycardia, of course, it's present as the heart attempts to compensate for everything. We see a narrowed pulse pressure, start to see some acute mental status changes, and then dizziness can certainly occur due to some reduced cerebral perfusion. All right, so let's talk about cold and wet presentation of cardiogenic shock. Now, this is the most common clinical presentation that we'll find. So cold skin, the patient's skin may feel cool to the touch, and that's once again due to that peripheral vasoconstriction. They can have some pulmonary crackles on auscultation, so those sounds indicate fluid in the lungs, and that's a sign of pulmonary congestion or edema. They can have ashen or cyanotic appearance, an altered mental status, of course dyspnea and orthopnea, JVD, peripheral edema, third and fourth heart sounds. So remember when we went back, we talked about S3 and S4, so those sounds may be audible during auscultation, and that indicates heart failure or volume overload. And then probably a decrease in systolic blood pressure. So that blood pressure may drop due to the heart's impaired ability to pump effectively. So whenever we're still talking about the assessment, but now we move down to kind of gathering some history. So if family members are around, they're present, we'll try to find out about a history of heart disease. And then we do want to find out about medication compliance. So, A, what meds are they taking? And B, are they compliant with them? And then some meds, might look for specific meds, so maybe beneficial to identify which meds the patient was prescribed, especially those related to heart conditions. So antihypertensive, coagulants, heart failure meds, so more, just kind of drilling down into some specific meds. Now, management, we know we want to get some O2, we know we want to monitor their ventilatory status, get an IV, continuously monitor the SCG or the ECG. Want to make sure that we're looking for signs of arrhythmia or ST segment changes, and then transport for definitive care. So these need to be a rapid transport, get them hopefully going to a cardiac unit, or just the ER, of course, depending upon the where you're at and status of your patient. So in hospital management, they are going to focus on contractility, so they're going to use things like inotropes to help strengthen the contraction. Now, we want to make sure that we're administering fluids cautiously because we want to optimize filling pressures without causing fluid overload. And then for afterload, use vasodilators if necessary to reduce systemic vascular resistance, and that can help improve the cardiac output. And then controlled dysrhythmias, we want to make sure that we're controlling them, as well as I know I mentioned the in-hospital of what they're going to do, but that's also going to be for us. We're going to pay attention to blood pressures, and we may need to use a pressor as well. We may need to use something to get pressures down, but we do want to control the dysrhythmias and then positioning of the patient. So hypotensive patients, we want to put them in a supine position to promote venous return and improve blood flow to vital organs. And then with patients with pulmonary congestion, we want to position them sitting up with their feet dangling, help alleviate dyspnea and improve respiratory function. Then of course we want to minimize any physical exertion, just because we want to try to reduce that myocardial oxygen demand and allow their heart to stabilize the best that it can. So we want to get vital signs, obviously get a pulse ox, put them on the monitor. They're already on O2. We want to keep them at least greater than 92 if possible. We set a monitor 12 lead, and then in the event that you need to do some fluids or meds based upon your protocols, maybe you need to talk to your med director, maybe you don't. That's all going to be based upon your protocols. Now, some vasoactive IV meds that we're talking about for cardiogenic shock. So some meds that are used, you might see dopamine would be a good choice, and that increases that cardiac contractility and heart rate, and that's obviously dependent on the dose. You should remember that. And then norepinephrine, so it's primarily a vasopressor, but it increases systemic vascular resistance and blood pressure as well. And then we know epinephrine, it increases the heart rate and contractility and can also act as a vasopressor. Now, frequently make sure that you're checking your IV site for signs of infiltration or even phlebitis. So as vasoactive meds, they can be caustic to tissues. And then continuously evaluate your patient's hemodynamic response, including blood pressure, heart rate, just overall clinical status. Now, except for addressing life-threatening dysrhythmias, not many additional measures to stabilize a patient in cardiogenic shock in the field. So really our whole focus should be on stabilizing the best we can and then a rapid transport to a medical facility. All right, refusal of care. So, first off, you should have some protocols that are based upon AMAs or refusals. Obviously, when you have someone that's really sick, especially if they're in cardiogenic shock, we need to do a good job of explaining things to them. So we want to repeatedly just urge the patient, calmly, empathetically, encourage that patient to accept assistance. We want to explain the seriousness of their condition and the potential risks of refusing treatment. Now, based upon your protocol, you may or may not do something like this. In my opinion, seeking advice is a good idea from your med direction. So if that patient continues to refuse care, consider contacting your medical director for guidance on how to proceed. They may provide additional strategies or support in handling that situation. And then, of course, documentation. So document that refusal. It's important to accurately document the patient's refusal of care. And then include some details like their mental status and their understanding of their condition, the reasons they provided, that the patient provided for refusing care, and then any information or alternatives presented to the patient to encourage acceptance. All right, shifting gears, hypertensive emergencies. So that's the hypertension, we know, is just defined as a systolic blood pressure exceeding 140 and this diastolic exceeding 90. So it's often called the silent killer due to its lack of obvious signs or symptoms. And the thing is, chronic hypertension can damage the heart, the brain, the eyes, the blood vessels, and the kidneys. So, and when we talk about hypertensive emergency, what that is an acute elevation of blood pressure, to 180 over 120, of course, or higher, with the evidence of end organ damage. So, some of the common causes that we're looking at here is just that non-compliance with their meds, history of hypertensions, and then even some conditions. So maybe an acute aortic dissection, acute kidney failure, drug-induced hypertension, even toxemia of pregnancy can cause that. Now, some underlying causes of these hypertensive emergencies, we see advanced atherosclerosis or arteriosclerosis. So most cases of hypertension, particularly those leading to emergencies, are due to these conditions, which involve the hardening and narrowing of arteries. And this impairs blood flow and increases vascular resistance. Various conditions, such as anxiety or pain, can temporarily elevate the blood pressure, so we can see some transient elevations. Now, a single elevated blood pressure reading does not necessarily indicate hypertension. It's essential to consider the context and the frequency of your readings as well. Now, if a patient presents with a single elevated reading, suggest they have their blood pressure rechecked a couple of times over the following weeks to confirm whether hypertension is persistent. So some persistent diastolic elevation, so that consistent elevation in diastolic blood pressure, that's a strong indicator of hypertensive disease. So this condition can have serious health consequences, including obviously a shortened lifespan, and then there's an increase of some risk of some medical conditions. So renal damage, that long-term hypertension can impair kidney function, and that can lead to renal failure, as well as a stroke and heart failure as well. Now, rapid intervention is required for these hypertensive emergencies, and it may necessitate the rapid lowering of blood pressure to prevent or limit organ damage. So some potential consequences if it's untreated is you might see a patient might see acute renal failure, an MI, stroke, or obviously even just death. So assessment, when we talk about hypertensive emergencies, with rapid development, these hypertensive emergencies, they often develop quickly, and that necessitates some prompt assessment and interventions. Some of the things you might see, those signs and symptoms that you might see, a headache or blurred vision or sudden blindness, aphasia, so some difficulty speaking or understanding speech, it can signal some neurological impairment, numbness or weakness. So focal neurological deficits can indicate a stroke or maybe even a TIA, so a transient ischemic attack. And then mental status changes or something, as well as widespread neuromuscular irritability. So what I'm saying is, it's not just this increased muscle tone or twitching that can be observed. So some cardiovascular signs and symptoms secondary to these hypertensive emergencies, obviously chest pain or tightness, shortness of breath, palpitations, dysrhythmia, signs of heart failure. So you might see some peripheral edema or JVD, and then sudden severe chest or upper back pain, especially concerning in the event we're thinking of aortic dissection. Now, some additional signs and symptoms, so they may have a decrease or absence of urine output, and that can indicate acute kidney injury, and that would obviously be something that was asked in the interview. Nausea and vomiting can occur due to increased intracranial pressure or even GI involvement, or tinnitus, so that ringing in the ears. It can be associated with elevated blood pressure. Nosebleeds are really common in hypertensive crisis, as well as muscle cramps. That can be secondary from electrolyte imbalances, even all the way up to organ dysfunction. So we see peripheral pulses, so strong or bounding pulses. They may be more pronounced in cases of severe hypertension. So make sure you're checking and documenting the patient's blood pressure in both arms. That's pretty important in cases of suspected aortic dissection. It's crucial in cases such as these, as differences in readings may indicate compromised blood flow. So some other things you might see, now we talk about neurological, some seizures. Obviously we mentioned signs of heart failure, as well as signs consistent with an MI, or you might even see some ischemia on a 12 lead. Now, medication history, you want to make sure to ask the patient or family about all the meds that they're taking. So prescribed meds, over-the-counter meds, even recreational drug use, because that could be a big part of this. So our care, when we start talking about this, obviously supportive care, we want to make sure that we're getting people on an O2 and IV and monitor. We want to target their SpO2 between 95 and 98 if that's possible. With these hypertensive emergencies, want to make sure that we do a rapid transport to the medical facility that's proper for them, and then follow our protocols. Heart failure, we implement appropriate care measures based on the patient's condition, and then that chest discomfort, so assess and treat according to our protocols, which may include administering nitro or aspirin. However, if they're in failure, then probably not, because we might assume that their pressure is kind of cruddy. And then we see some reassure the patient and family. So want to make sure that we're talking with them throughout this process. Clear communication about the situation and the steps being taken typically will help alleviate some anxiety. So some field drug therapy. So if we're talking about a long transport, if that's unavoidable, then if the transport time is extended, then paramedics need to start some drug therapy in the field. So you might look at things like labetalol. So that medication has both alpha and beta blocking properties, and that helps decrease the overall peripheral vascular resistance, as well as prevent some reflex tachycardia. Now, it's not recommended for patients with asthma or COPD, and that's due to the potential for bronchoconstriction. So as we move down, we see some patient positioning kind of things. So we want to make sure that we keep our patient in a supine position to optimize the blood flow and then reduce cardiovascular strain, as well as monitor their blood pressure frequently. And then discontinue the medication whenever that blood pressure has fallen to the target level, as per your protocol, of course. And then we want to transport them to the appropriate facility. Now, refusal of care here is much the same, really, for all of them. If for a sick person, one thing we need to do is educate. Obviously, we need to urge them to allow us to treat them and transport them. However, sometimes people don't want to do that, but we want to encourage them to accept care. It may be necessary to contact our medical director, and once again, document. So record that refusal. It's crucial to document the patient's refusal of care thoroughly. So their condition, their vital signs, anything that they said. I think quotation marks are really good in this. If you've been to court, it's really good to have quotation marks around what that patient said in the event it didn't work out so pretty good after you took off. All right, infectious diseases of the heart. This is about as exciting as it sounds. However, we're going to get through it. Just hang on. So let's talk about endocarditis. So endocarditis, that's just an infection of the inner lining of the heart, and known as the endocardium, and it's characterized by inflammation. It should make sense, all putting those words together. And that condition typically occurs when bacteria enters the bloodstream, and it colonizes the heart valve or other damaged tissue within the heart. And the bacteria begins to multiply, and then it leads to infection and inflammation. So you can see that their bacterial infections are the most common cause from these. Some risk factors include some pre-existing heart conditions, prosthetic heart valves, and IV drug use for sure. So symptoms that we might see: fever and chills, heart murmurs, fatigue, shortness of breath, or even what's called Janeway lesions or ossular nodes, and those are just some skin manifestations that you might see secondary to this. So diagnosis typically confirmed through some blood cultures and then echocardiogram. So that visualizes the growths on the heart valves. Treatment usually involves prolonged courses of IV antibiotics, maybe even some surgery. However, we don't really do much of that. Now, some high risks here, people that are at the highest risk of this, we're talking about they have mitral or aortic valve disease. So pre-existing conditions affecting these valves, they increase susceptibility to infection. And then prosthetic heart valves, so if they have artificial heart valves, they're at a significantly higher risk due to potential sites for that bacterial colonization. And then people with congenital heart disease, so patients with structural heart defects are more prone to developing endocarditis, as abnormal blood flow can lead to endothelial damage. Now, there is some right-sided endocarditis that you see listed, and right-sided endocarditis primarily affects the tricuspid valve and the pulmonary valve. So some common populations for this, again, is some IV drug users, patients with infected central venous catheters, dialysis shunts, as well as transvenous pacing wires. Those can all be sites for infection or causes. Now, when we look at this, we see symptoms like fever, chills, headache, loss of appetite, weight loss. There's not much of this that really should surprise us. However, we do see some ECG changes that may be seen, and that can include a prolonged PRI, third-degree block, or a left bundle branch block as well. So care for this, again, is going to be supportive. Get you an IV, put them on the monitor, keep your O2 monitored, and roll out. Treatment there in the hospital, they need antibiotics, maybe surgery. Once again, that's not something that we're going to do. However, if they refuse care, just back up about 5 minutes and just re-listen to the thing again. Make sure you urge them to go. Make sure you document everything. All right, pericarditis. So this is just an inflammation of the pericardium. So pericarditis is that inflammation of the pericardium. And remember, that's that fibrous sac that's surrounding the heart. So viral infections are the most common cause, often following a viral illness. But bacterial infections can happen, as well as fungal infections. So bacterial are less common, but they can occur. And then fungal infections are rarely implicated. Now, in some cases, there's no identifiable causes found. So that's called idiopathic, when we're unsure of what caused it. So that's idiopathic pericarditis. Now, when you're taking a history, ask that patient about any recent flu-like signs and symptoms. They may report a history of recent upper respiratory infection. And the things we can expect with this are, some of the most common symptoms: that sharp stabbing chest pain. It often worsens with deep inspiration or coughing or lying flat, as well as pain typically decreases when the patient sits up and leans forward. So it's kind of producible chest pain versus non-reproducible. So by having a big cough or a deep inspiration or a deep expiration, that's something that changes it. Whereas with MIs, typically we don't see that. Now, heart sounds, listening may reveal a pericardial friction rub, although this sign is not always present. And some other signs we might see is fever, tachycardia, tachypnea, pale skin, JVD, breath sounds, typically normal unless another condition is present. And you might see we mentioned it in the EKG as well as earlier. You'd see some ST segment elevation in multiple leads, really more just diffuse or almost global elevation. So supportive care are going to be a big thing, just that comfortable position for them, cardiac monitoring, O2, 12 lead, and then get them to where they need to go. Now, medication management, in the event that you guys use some non-steroidal anti-inflammatory drugs, typically those are the first line treatment for pericarditis to reduce inflammation and pain. However, that may not be something that's within your protocol, but make sure that you're aware of what's in your protocol. So depending upon the etiology of how this was, how they, contracted this. So viral pericarditis, it often resolves spontaneously, so supportive care is usually sufficient. And then bacterial typically requires treatment with some antibiotics, and then fungal, as you can imagine, treated with some antifungal. Now, you see that last one, so refusal of care. Same thing, guys. Not a lot to talk about with refusal of care. Do a good documentation and urge them to go get seen. So myocarditis, that's that inflammation of the myocardium. It's usually benign and self-limiting. So if untreated though, it will impair the heart's ability to pump, and it may result in some right or left ventricular failure, dysrhythmias, maybe some death, even dilated cardiomyopathy. Now it can be caused, much like what we just talked about, bacteria, viruses, even parasites, heart transplant rejection, rheumatic fever. So when we look at the assessment, most cases are associated with flu-like symptoms for which the patient does not seek care. So they have those flu-like symptoms probably, fatigue, decreased appetite, mild shortness of breath, maybe some joint and muscle aches and pains, fever, palpitations, all of those kinds of things. You might also see an atrial or ventricular dysrhythmia as well, or even a bundle branch block. So you may see some low voltage QRS complexes. So those low voltage QRS, just imagine just small, typically, as long as you haven't adjusted your monitor, just some small QRS complexes, as well as pathologic Q waves. I don't think I mentioned what that meant earlier when we were talking about it. Pathological Q waves are typically wide as well as long. So it's not just that short little Q wave. There are some specific measurements that I want you to look into, but typically it's just a little bit wider of a Q wave, as well as the depth is a specific measurement as well. And you can see some other non-specific ST segment and T wave abnormalities as well. Now it might be a little hard, it might be a little confusing when you're looking at this, because some of the same things are with ACS and aortic dissection and heart failure and pulmonary disease and all of that. So you gather all your information and you just move forward the best you can. Now management, not a lot of different. Allow them to assume that position of comfort, get an IV, cardiac monitor, pulse ox, put on some O2, and obtain a 12 lead, and then get rolling. All right, we're getting there, so hang on. So rheumatic fever. Rheumatic fever, that's an inflammatory disease, and it can develop following an infection with streptococcal bacteria, and that's commonly known for causing strep throat. So streptococcal infection, that disease typically arises after untreated or inadequately treated streptococcal throat infections. So you can start to have some cardiac complications. So rheumatic fever can lead to scarring and narrowing of the heart valves, particularly the aortic and the mitral valves, resulting in some stenosis and potential heart complications. So once again, we're going to evaluate the symptoms, history of recent streptococcal infections. That should maybe point us in that direction. Symptom management, you may use some pain relief for any chest pain or discomfort. Of course, you're going to monitor the vital signs, O2, and transport. And here we go. We're going to keep going. So scarlet fever, that's just that infectious disease that's caused by another streptococcus bacteria, and it's also responsible for strep throat. So common signs and symptoms obviously would be sore throat, some fever, potentially a rash. There's something called strawberry tongue that you can see with this, and it's that where the tongue may appear red and bumpy, and it kind of just resembles a strawberry. So patients younger than 1 year of age are at the greatest risk of developing scarlet fever. So the treatment is going to be antibiotics for this, help eliminate that infection. So for us, it's symptom relief, maybe some fluids, and then monitoring and all the other stuff that we do. All right, so an aneurysm. So an aortic aneurysm, it refers to the dilation or the outpatching of the aorta, which is the largest blood vessel in the body. Now this can occur in any segment of the aorta. It could be ascending, descending, or even abdominal. Now, if the wall of the aorta tears, then a serious condition called a dissection can occur. So dissection, it may begin with a tear in the inner lining of the aorta or the intima near the weakened section of the vessel, and then blood can flow through this tear and enter between the layers of the vessel wall, and that exposes the middle layer, so the media, to the high pressure blood flow. And then as blood fills the space between the layers of the vessel wall, it causes them to separate or dissect, that's where that word comes from, which can lead to a life-threatening emergency. So aortic dissection, it can result in severe complications, including the rupture of the aorta, which can lead to massive internal bleeding and is often fatal without immediate medical interventions. So during each ventricular contraction or systole, blood is forcefully ejected into the aorta. So if there's a tear in that aortic wall, then it can lead to this false channel creation, which is what you see on your slide. So blood enters the torn area and it forces its way into the layers of the vessel wall, and that creates this false channel between the inner and the middle layers, so the intimal and the medial layers. Now, dissection extension. So if the dissection extends back towards the aortic valve, it can have some pretty significant repercussions. So the aortic valve may not be able to close properly due to the structural changes and the separation of the wall layers. So we would see some valve dysfunction, as well as some blood regurgitation. So, it can lead to blood regurgitating into the left ventricle during systole, which can increase the workload of the heart and lead to heart failure over time. Now, the dissection can also compromise blood flow to the coronary arteries, which supply the heart muscle with oxygenated blood. So because of reduced coronary blood flow, we might expect to see ischemia, so chest pain, angina, even an MI. So if the dissection affects the takeoff points of the critical arteries, such as like the innominate artery, so that's a large artery which branches into the aortic arch, and it divides into the right common carotid and the right subclavian arteries. You could see some dissection affect that, as well as the left common carotid artery or the left subclavian artery. So blood flow through these affected arteries will be diminished, potentially leading to ischemia in the brain and upper extremities. So for an ascending aorta, most dissections begin in the ascending aorta, typically within 2 inches or about 5 centimeters of the aortic valve. And then some dissections originate at the site of the ligamentum arteriosum, and that's a remnant of fetal circulation, and that would be a descending thoracic aorta. There's lots of risk factors, things like tobacco smoking, high blood cholesterol, hypertension, coronary heart disease. So when we talk about this word, there's also a cystic, hang on, sorry, I just lost my spot. Cystic medial degeneration. So this condition is a common cause characterized by the replacement of normal elastic tissue in the aortic wall with cyst-like connective tissue. So, you have this mild form of this degeneration can be seen in the aortas of older adults, often as a natural consequence of aging. And then there can be some congenital issues as well. So untreated infections, trauma, infective endocarditis as well. So the signs and symptoms of an aortic aneurysm and dissection, it can vary based on the location within the aorta. So a large aneurysm may exert pressure on surrounding organs, leading to symptoms such as like abdominal pain or discomfort, respiratory difficulties if the aneurysm compresses the lungs, or even some neuro symptoms. Now the patient pain description, that's typically something that kind of pushes us in that thought process, and the nature of that pain reported by the patient can provide some important clues regarding the location and severity of the dissection. So most patients experience an abrupt and sudden onset, often described as like constant and unbearable, so that pain doesn't fluctuate significantly, and many describe it as severe and incapacitating. So some of those potential pain locations, chest pain, back pain, often in the chest pain where it can indicate a dissection in the ascending aorta. And then in the back pain, it's often associated with a dissection in the descending aorta. And then abdominal pain can suggest involvement of the abdominal aorta as well. So substernal pain, some patients may report severe pain located behind the sternum. Radiating may move all the way to the neck, the throat, the jaw, the face. And then that was ascending aorta, and then descending. So this is where you start thinking about flank pain. So patients often experience the pain on the sides of the body or pain between the shoulder blades. So it's a common symptom that may indicate involvement of the descending aorta. And then dissecting aneurysms in the descending aorta can cause pain that radiates to these areas, potentially complicating the clinical picture. Now, let's talk about differentiation from an MI. So while a chest pain from a dissecting aneurysm, it may resemble that of an MI, certain features can help differentiate them. So just that quality of pain, the dissection pain is often described as sharp and tearing. When you hear the word tearing, that should always make you think, at least be thoughtful about a AAA or some type of aneurysm. So whereas MI pain is typically pressure-like or squeezing. And then onset dissection pain generally has a sudden onset, while MI may develop gradually. And then the specific radiation pattern, so neck, jaw, back, for this is associated with dissections. It may differ from typical MI presentations. And then dissections may present with additional symptoms, such as some neurodeficits if blood flow to the brain is compromised, or signs of shock as well. And then some symptoms: anxiousness, that feeling of impending doom, pain, weakness, numbness, tingling, signs of myocardial ischemia, heart failure, altered mental status, stroke, all the things that you see there. All right, let's talk about some patient demographics for ascending aorta dissection. So ascending aorta dissection is often seen in younger individuals who have previously been in good health, indicating that these events can occur outside of just the typical risk factors. So there are some clinical indicators. We see dissecting may compromise one or more of the vessels that's stemming from the aortic arch, which can lead to significant clinical implications. So we see some vascular compromise. Also see some blood pressure discrepancies, so arm pressure differences. So a pressure difference greater than 20 millimeters of mercury between the arms may indicate the presence of an aortic aneurysm or dissection. And this finding is critical in the assessment process. Also some acute neurological symptoms. So if the blood pressure discrepancy is accompanied by acute neurological changes, this really raises the suspicion for a dissection. So you might see some confusion, some weakness, as well as speech difficulties. And then you might see some things where they are exhibiting some signs and symptoms of a stroke, and that's due to that compromised blood flow to the brain. And so including like sudden numbness or weakness, especially on one side of the body, difficulty speaking or understanding speech, as well as some vision problems. Now, older patients. I said we were going to talk about patient demographics. So we talked about some younger patients, now older patients. So descending aorta dissections, they're more frequently observed in older individuals, particularly with those with a history of hypertension, and that obviously contributes, man, it's getting rough, to a vascular degeneration. Now, some pain characteristics of this, and we're talking about a descending aortic dissection. Some pain characteristics is that pain associated with that descending aorta dissection is generally less severe than that of an ascending aortic dissection. However, it can still be significant and should not be underestimated. Some clinical indicators when we start talking about this is you can have a diminished pulses. So patients may have a weak or hard to feel distal pulse due to compromised blood flow. And then of course there's potential complications. So, if you have a rupture of the thoracic aneurysm, then a hemothorax is something that could happen. So if that dissection ruptures into the pleural cavity, signs of hemothorax may be present, and that includes some chest pain, some difficulty breathing, and then of course that dullness to percussion on exam. And then tamponade. So if that dissection ruptures into the pericardial cavity, signs of cardiac tamponade may occur. So we might see things, as we talked about, hypotension, JVD, muffled heart sounds, so that Beck's triad. Now, when we start thinking about a rupture of an abdominal aortic aneurysm, sudden back pain is something that's really typical. So rupture typically presents with sudden onset of severe back pain. They may also exhibit some abdominal pain and tenderness. Hypotension would be a big thing. Maybe a pulsating abdominal mass. So pulsating mass may be palpable between the xiphoid process and the umbilicus, and that's often accompanied by tenderness. And then abdominal distension, as well as some GI hemorrhage as well. Now, when we talk about management of it, pain relief, rapid transport. Not a lot for us to do here. So a couple big things. We need to make sure that we're notifying medical control that that's what we think that we're bringing in. And then avoid delays. So don't mess around on scene. Don't, not even with an IV, make sure you're getting that on the way to the hospital. Cardiac monitor, O2. Administer fluids for your local protocols. The thing is, you want to maintain blood pressure and perfusion. Medication also would just be based on your local protocols. There's some differing thoughts on that, but you guys do what your local protocol says would be the right thing to do. And then reassessment. This is somebody that's definitely critical, every 5 minutes. Oops, sorry. My gosh. All right, so occlusion. Sudden disruption of arterial blood flow that occurs because of 4 different things, and we're going to talk about those. So that occlusion, mentioned, it's a sudden disruption of arterial blood flow, and it can significantly affect tissue perfusion as well as function. So the causes of that occlusion, we can see a thrombus, so a blood clot that forms within a blood vessel, and that leads to obstruction of the blood flow. And when a thrombus affects an extremity, the blood supply to the muscle is restricted, which can lead to ischemia as well as associated symptoms. So, during that physical activity, these muscle contractions increase demand for oxygenated blood. And if a thrombus is present, then that can further limit blood flow, and that potentially leads to pain or cramping, commonly known as claudication. So we're talking about muscle contraction during exercise. So if someone tells you that they have that, then that would hopefully direct you there. Now, the process of occlusion often occurs gradually, allowing time for the body to develop collateral circulation. And what that is it's alternative pathways for blood flow. So the body compensates for this and starts creating a whole new path for blood to flow to get to the proper areas. Now, if extensive collateral circulation develops, then patients may notice little to no change in symptoms, or even only a mild increase in discomfort during exertion. And this adaptation, it can mask the presence of significant occlusions. So an embolus, that's the most common when we're talking about these occlusions. So an embolus is a substance that travels through the bloodstream and it lodges in a blood vessel, causing obstruction. So some conditions favoring embolus formation, things like atrial fib. So irregular heart rhythms can lead to the formation of clots in the heart, particularly in the left atrium, and then clots in the left ventricle as well. So after an MI, blood clots can form in the left ventricle due to damaged heart tissue. And then conditions involving rheumatic heart disease or prosthetic heart valves, that can predispose patients to clot formation as well. And then a left ventricular aneurysm. So this condition can also lead to thrombus formation within the heart. And some common locations of lodging. So these arterial emboli, they can travel to various sites in the body, but they frequently lodge in the femoral artery, and that can lead to acute limb ischemia. Now, most of these embolic events, they occur in patients with significant underlying heart disease, increasing their risk of complications. And then there's even tumor-related occlusions. So tumors can also cause arterial occlusions by direct compression. So a tumor may compress nearby blood vessels, restricting blood flow. And then tumor fragments or associated thrombi can dislodge and travel through the bloodstream, and that leads to embolic events as well. And then direct trauma to the artery. So direct trauma can lead to arterial occlusion through various mechanisms, including the extremity injury. So trauma to the limb, such as a fracture or severe lacerations that can damage the arteries directly, leads to hemorrhage or occlusion. So a dissection, dissecting aneurysm, a dissection can compromise arterial integrity, leading to the occlusion or reduce blood flow downstream. And then we see maybe some vasospasms that are often associated with IV drug use. So the vasospasm can cause temporary or permanent constriction of the artery, leading to ischemia. And then some vascular grafts that can be they can become occluded due to thrombosis, atherosclerosis, or even kinking, impeding that blood flow. So we can see some of this from blockage of a vascular graft. And then, of course, there's just the unexplained origins as well. There's always something where nobody has a clue. All right, acute limb ischemia. So acute limb ischemia, that occurs when an arterial occlusion, it suddenly reduces blood flow to an arm or a leg, and that potentially leads to tissue damage and loss if it's not properly addressed. So occurrence for this, about 10% with peripheral artery disease experience intermittent claudication, and that's characterized by pain, cramping, muscle tightness, fatigue, or weakness. Now, symptoms arise due to increased O2 demand in the muscles during activity, which cannot be met because of the restricted blood flow. So these arteries that are supplying the calves, hips, or buttocks become narrowed or blocked by atherosclerotic plaques, leading to limited blood flow to these tissues. So resting is something, resting is something that many times will help the symptoms to resolve after a brief rest, and then they're able to resume their activity. But there is some atypical presentations. So approximately 40% of patients may not report those classic leg pain, but instead describe atypical symptoms such as leg tiredness or fatigue. And then about 50% of patients may be asymptomatic despite an abnormal pulse examination, or exhibit leg symptoms that differ from the classical claudication. And that's a condition it's characterized by muscle pain or cramping that occurs during physical activity, typically in the legs. And then once again, that's just due to that inadequate blood flow. So make sure we get a good history. Sudden onset versus gradual onset. And then has this happened before? So let's talk about on the assessment, the 5 Ps. These are going to be pretty important. So the first thing we have is pain. So, that typically begins distal to the site of the obstruction, and it increases in severity as the ischemia progresses. And then in advanced cases, there may be a decrease in pain due to significant sensory loss. So our second P is pulselessness, and the absence of a pulse in the affected limb. That's obviously a critical sign, indicates a lack of blood flow to that area. And then pallor, so the affected limb may appear pale or have an abnormal color, and that's just reflecting that inadequate blood supply. And then paresthesia, so tingling or numbness. It can indicate life-threatening ischemia, and that suggests that the nerves are compromised due to the lack of blood flow. And then paralysis, so weakness or inability to move the affected limb is another sign of life-threatening ischemia, and that indicates just that severe damage to both muscle and nerve tissue. All right, assessment. So we want to identify whether the patient has any risk factors for developing a blood clot, including recent extremity history or IV drug use, maybe heart surgery, or they had an MI. Those can lead to emboli. Clotting disorders, obviously. Pulmonary embolism. That history can indicate they have a propensity for clot formations. And then atrial fib, so if they have an irregular heart rhythm, that can lead to that clot formation in the heart. Contraceptive use, hormonal replacement therapy, rheumatic heart disease, that increases the likelihood of thrombus formation. So we're still talking about assessment. So, usually when we talk about kind of the appearance, the skin typically appears pale or mottled distal to or over the affected area. And the foot may turn pale when it's raised and become very red after being lowered below the heart level. And that affected limb, it can be cool. The skin can either be moist or dry. And then, of course, a pulse assessment. So palpate brachial, radial, femoral, posterior tibial, or even dorsalis arteries in pairs. Peripheral pulses may be absent or diminished in the affected limb. And then assess the movement and the sensation. And then we want to do a cardiovascular assessment. So heart rate, rhythm, blood pressure, auscultation. And then you see chronic limb ischemia. So, we want to watch for signs of chronic limb ischemia, particularly in patients with a history of peripheral arterial disease, which may include some skin changes, maybe hair loss on the legs, or even ulceration or gangrene in advanced cases. So the management. Allow them to assume a position of comfort to help alleviate the anxiety as well as improve circulation. And then talking about lower extremity care. So if the limb ischemia affects the lower extremity, we want to sit the patient up and position their feet lower than the chest. That can enhance venous return and help maintain blood flow. Nothing new, IV monitor, O2, all of those things as well. Just general supportive care. And then follow your medical direction. So, they may have you use some appropriate analgesics for that. Now, make sure you want to warm your ambulance compartment. So keep that patient compartment warm to prevent clot-induced vasoconstriction. And that can exacerbate the ischemia and reduce blood flow to the affected limb. And then a rapid transport. These people are pretty sick and have some serious things going on, and we need to get them going. So we want to monitor, and for us in management, monitor those 5 Ps. We want to continually assess those throughout the transport. So this ongoing evaluation is going to be important to identify any changes in their condition that may require immediate intervention. And then we want to handle them with care. So, we want to hopefully encourage them to take our care, to take an ambulance ride to the hospital, and then once again, if they don't want to go, then we document their refusal well. If you'll hang with me, we're almost there. I know I've said this probably already, but we really are this time. So acute deep vein thrombosis. So thrombophlebitis, that refers to the development of a blood clot in an inflamed or damaged vein, and it can occur in both superficial and deep veins. So superficial, that involves veins near the surface of the skin and typically includes redness, swelling, tenderness, all the things that make sense. Deep vein, that occurs in the deep veins of the extremities, often in the legs. That may include some swelling and pain and warmth and tenderness in the affected limbs. However, as we've mentioned with some other things, they could be asymptomatic as well. Now, DVT is associated with a significant risk of a PE, so they're at risk for pulmonary embolism, and that's a serious complication that occurs when a clot breaks free and it just travels to the lungs, potentially causing life-threatening consequences. So some factors that contribute to this is venous stasis. So venous stasis, that refers to sluggish blood flow in the veins, and it can lead to clot formation. So some of the people that we might see with that is like pregnant patients, immobile individuals, obesity, heart failure. And there's damage to the inner lining of the vessel. So injury to that vessel can initiate clot formation. Start to see some inflammation. So some conditions that cause inflammation can damage that endothelial lining. And then some invasive procedures that can create sites for clot formation. So certain meds or irritants may damage the vessel lining during administration. And then some part of this is with some blood clotting disorders as another important factor. And the causes are like dehydration, even certain cancers, and then hormonal treatments as well can increase that. So some presentation. Swelling, one limb, usually a leg, may appear swollen compared to the other. They may report localized pain or tenderness, warmth and redness. And then we want to look for risk factor evaluation. So, we want to ask them about factors that may increase the risk for DVT. So things like recent surgery or hospitalization, immobility, maybe they have a history of DVTs, obesity, pregnancy, chronic conditions, meds, age. And then a physical assessment. So carefully assess both upper and lower extremities for signs of DVT. You want to compare those extremities and look for like swelling and color changes and temperature. And we want to look for signs of inflammation. So signs of inflammation over that affected vein, including some redness, heat, swelling. So in assessment of the calf pain, while examining the calf muscle, you want to perform the following. So dorsiflexion of the foot. So with the leg straight, gently dorsiflex the foot. So pulling the toes towards the shin. Observe for pain. If the patient experiences pain in the calf, that can indicate a DVT. However, the sign's not definitive, and it should be interpreted with caution. So if they have something like that and they have all the other signs and symptoms associated, then it's probably a good idea to think, it could be this. However, make sure you don't rub or massage anything. Avoid rubbing or massaging the affected limb. The big thing about that is manipulating that limb, it could dislodge a clot, and that leads to a thromboembolism, which is a serious complication. Now, some differential diagnosis, so some other things that you might be thinking about. So arthritis, the inflammation of the joints that can cause pain and swelling and stiffness. Typically involves joint pain, which may be accompanied by redness and warmth, but it's usually localized rather than diffuse. And then cellulitis, also that bacterial skin infection, maybe a muscle or a soft tissue injury, and then maybe superficial thrombophlebitis. So that involves inflammation and clot formation in a superficial vein, often near the surface of the skin. So similar to DVT, but typically presents with localized redness, warmth, and tenderness along the vein without significant swelling of the entire limb. Now, supportive care is going to be our big thing. Here again, comfortable position, let them assume that position of comfort. Elevate the affected limb, may help reduce swelling and discomfort. IV cardiac monitor O2. You might have protocols for pain meds, and then close monitoring for any signs of a PE, because as we said, it can get mobilized and get pushed up into the pulmonary system. So that sudden shortness of breath or chest pain, rapid heart rate, coughing up blood. And then transport. So if possible, transport without lights and sirens, trying to keep the stress and everything a little bit lower. Now, patient refusal, I'm not going to go into that again. It's all the same with these. Your patient refusal process should be solid, especially with critical people, with anyone. Anybody will take you to court, but especially with critical people. So make sure that you're doing a good job of documentation on that, educating the patient that this may not go well for them, and maybe contacting your medical control. And there it is. Holy moly. Well, if you're still with me, I appreciate it, and we'll talk again soon.